I want you to take a second and just, really try to visualize your brain.
Right?
Because usually, when we try to picture the human brain, we default to this image of a supercomputer, don't we?
Yeah, we think of hardwiring and processors.
Exactly. We think of silicon chips, motherboards, data neatly filed away in little digital folders that you can just click open. But I want you to throw that image entirely out the window today.
Good, because it's terribly inaccurate.
It really is. Instead, picture a massive world-class symphony orchestra.
Oh, I like that.
Right? You've got the strings section handling your memories, the brass section powering your language and speech, and the percussion driving your physical motor skills.
All playing together.
Exactly. And up front, standing right on the podium, is the conductor. They are coordinating every single beat, every volume change, every tempo, so the music actually makes sense.
Which is a brilliant way to frame it.
But now, think about what happens if the sheet music starts to physically fade away.
Oh.
Or if the violins suddenly fall completely out of tune. Or, most terrifyingly, what if that conductor just steps off the podium, drops the baton, and walks out the door?
Total chaos.
Exactly. The music doesn't just start neatly, it devolves into absolute terrifying chaos.
That imagery, it captures the stakes better than any clinical chart really could.
Yeah.
When we discuss neurocognitive disorders, we are fundamentally looking at what happens when the various sections of that neural orchestra lose their ability to play together.
Right.
We are dealing with a deeply interconnected, incredibly fragile ecosystem. These disorders demonstrate that the brain is not a machine where you can just, swap out a broken part.
Like changing a spark plug.
Precisely. It is a living network where a failure in one single area cascades into absolutely everything else.
And that cascade is exactly our mission for today's deep dive. We are exploring the incredibly complex, often heartbreaking, and I think widely misunderstood world of neurocognitive disorders.
There are a lot of misconceptions out there.
Huge ones. So we're working from a really foundational, incredibly dense source today. It's an introductory overview of cognitive disorders, brilliantly synthesized by Dr. Iqbal Ahmed and his colleagues.
It's a fantastic synthesis.
It really maps out the absolute front lines of how modern medical science understands, diagnoses, and frankly struggles to treat the aging and sometimes acutely injured human brain.
And the guiding philosophy we really must establish before we even look at a single disease is that these disorders are far more than just biological checklists.
Right. It's not just a list of symptoms.
No, not at all. We will absolutely delve into the microscopic plaques, the rogue proteins, and the failing synapses today. But ultimately, these conditions represent the profound intersection of the physical brain, the abstract mind, and the lived human experience.
They reveal the actual biological mechanics behind human personality, don't they?
They do. It's the biology of who we are.
So let's map out the territory, because we need a clear roadmap for where we are going today. We aren't just talking about memory loss.
No, which is what everyone assumes.
I think that's the biggest, most dangerous misconception out there, that cognitive decline just means an older person forgetting where they left their glasses.
Right.
We are going to explore a massive spectrum today. We'll start with the acute, subtly terrifying states of temporary confusion, which medicine calls delirium.
The sudden storm.
Exactly. Then we'll move into the slow, agonizing, permanent fades of dementia, things like Alzheimer's, the behavioral nightmare of frontotemporal dementia, and newly categorized diseases like late.
Which is fascinating new territory.
It really is. And finally, we are going to look at the crucial windows of time where intervention might actually literally reverse the clock.
Because to understand the decline, you first have to really understand the baseline. The source text gives us a sort of masterclass in the blueprint of the mind, referencing the diagnostic framework used in psychiatry, the DSM-5.
Right.
The DSM-5 doesn't treat cognition as one giant amorphous blob of just thinking.
It breaks it down.
Exactly. It divides cognition into 6 very specific measurable domains. We have complex attention, learning and memory, language, perceptual motor function, executive function, and social cognition.
Let's ground that in our orchestra analogy so everyone listening has a really concrete mental model of what is actually failing in the brain.
Good idea.
So complex attention, that's not just staring at a focal point,
Yeah.
right? That's the musicians actively listening to each other, maintaining hyper-focus on their own complicated part while deliberately ignoring, say, the person coughing in the third row of the audience.
Spot on. And executive function is unequivocally your conductor.
Right.
Located primarily in the prefrontal cortex, it's the part of the brain that plans, makes decisions, overrides impulses, corrects errors on the fly, and dictates the overall tempo.
And the memory would be the sheet music.
Yes, housed largely in the hippocampus. It's the physical record of what has been learned. Perceptual motor function is the actual physical dexterity of the musicians manipulating their instruments.
Like moving their fingers on the strings.
Exactly. And social cognition is how the orchestra interacts with the audience and with each other. It's reading the emotional context of the room to know if the performance is actually landing.
Dr. Ahmed's text makes it explicitly clear that these domains are strictly interdependent, doesn't it?
Very much so. They do not operate in a vacuum.
A deficit in just one of these areas ripples out and completely disrupts a person's life. If the conductor executive function starts to fail, the musicians might still have their sheet music perfectly memorized.
The memory is completely intact.
Right. But they can't play the song correctly because no one is telling them when to come in or how loud to play.
And that interdependence is what makes diagnosing cognitive decline so incredibly difficult in the real world. You almost never get a patient who walks into a clinic with a perfectly isolated failure of just one single domain.
It's always messy.
Incredibly messy. These physical cognitive deficits are almost always clouded by psychiatric symptoms. The text highlights how they present with severe mood changes, debilitating anxiety, and even psychosis. Add in pre-existing medical conditions, and you have a diagnostic puzzle with pieces that are constantly changing shape.
Wait, let me just challenge this interdependent orchestra idea for a second.
Go on.
Because if the domains are as strictly connected as you say, how is it physically possible for a disease to completely destroy the behavioral conductor while leaving the memory sections perfectly untouched? That seems contradictory.
It does sound contradictory, yes.
I mean, how often is a very real cognitive disorder completely dismissed by doctors or family members just because the person's memory is fine?
It happens constantly, and it is a massive failure in clinical observation. The domains are interdependent in function, but they live in distinct physical neighborhoods in the brain.
Ah, I see.
So if a neurodegenerative process physically shrinks the frontal lobe, which is the neighborhood where social cognition and executive function live, the hippocampus, where memory lives, might still be structurally perfect.
Right, the sheet music is untouched.
Exactly. So the patient remembers the exact date of their wedding from 40 years ago, but they suddenly start shoplifting or verbally abusing their spouse.
That's terrifying.
Because the memory is sharp, everyone assumes it's a midlife crisis or stress or just, getting cranky in their old age.
They completely miss that the crankiness is actually brain tissue dying.
They miss it entirely, yeah.
The text also explicitly notes that while we associate these disorders entirely with older adults, they strike younger adults too.
Oh, absolutely.
Traumatic brain injury, severe infections, or substance abuse can completely derail the orchestra in someone in their 30s or 40s.
Because the vulnerability of the brain isn't strictly tied to chronological age on a calendar, it's tied to the physical integrity of those domains. And while some of these declines, like Alzheimer's, are a slow, decades-long fade, there are other cognitive disruptions that happen virtually overnight.
Which brings us to the acute storm.
Yes.
Delirium. The terrifying sudden chaos of delirium. The text calls delirium ubiquitous in acute medical settings.
Ubiquitous.
Which is a very polite, academic way of saying it is absolutely everywhere in hospitals, and it is wreaking havoc on patients.
Delirium is an acute, fluctuating state of confusion. It is fundamentally different from dementia. If dementia is the slow rotting of the floorboards, delirium is a sudden house fire.
There's a great way to put it.
And it is highly problematic because, as the text notes, it very often superimposes on an existing, but previously unrecognized dementia.
So you have an older adult who maybe had some mild, unnoticed cognitive slipping at home.
Right. They were managing, okay.
They get admitted to the hospital for something entirely unrelated, a urinary tract infection, a minor fall, maybe a hip replacement, and suddenly they are completely untethered from reality.
They don't know where they are or what year it is.
What is actually happening biologically there? Why does a urinary tract infection, which is in the bladder, cause a house fire in the brain?
It comes down to neuroinflammation and neurotransmitters. When the body fights a severe infection or undergoes the physical stress of surgery, it releases massive amounts of inflammatory chemicals called cytokines.
Cytokines, right.
In a younger, resilient brain, The blood-brain barrier keeps most of that chaos out. It acts as a shield.
But an older brain.
An older brain, especially one already harboring the early stages of dementia, has a leaky barrier. Those inflammatory markers flood into the brain and completely disrupt the production of acetylcholine.
And acetylcholine is important
It's
because...
a critical neurotransmitter for attention and memory. And at the very same time, dopamine levels spike.
Oh, wow.
So you have a brain that cannot focus, being bombarded by hyperactive dopamine signals. The result is pure physiological chaos.
And the hospital environment itself is just adding petrol to that fire.
Oh, massively.
The text mentions deliriogenic medications, medicines that literally generate delirium. You take an older brain with a leaky barrier, put it in a bright, loud hospital room where machines are beeping at 3 in the morning.
Give it an infection.
Exactly, and then pump it full of new medications, and the orchestra just stops playing entirely.
And the presentation of that chaos is what makes it so incredibly dangerous. Delirium is highly variable. 1 hour, the patient might seem relatively lucid, and the next, they're hallucinating.
Right.
But the text calls out a specific, incredibly dangerous presentation. Hypoactive delirium.
Because when we hear delirium, our minds immediately go to the hyperactive version, don't they?
Yeah, someone thrashing about.
Exactly. Someone's thrashing in a hospital bed, pulling at their 5VN, shouting at the nurses. That's obvious. The staff sees it straight away. Hypoactive delirium is the exact opposite. It's quiet.
And what's fascinating and terrible here is how easily the medical system misinterprets silence as stability.
Yeah.
In hypoactive delirium, the patient becomes profoundly withdrawn and lethargic. They just stare blankly at the wall. They don't ring the call bell or cause any trouble for the nursing staff.
So they get ignored.
Because they are quiet, the text points out that this is frequently misdiagnosed as clinical depression.
To think a doctor looks at a quiet, withdrawn patient and assumes, oh, they're just sad about being in a hospital, when in reality, their brain is in a state of acute metabolic crisis.
They aren't depressed. Their neurons are literally misfiring on a massive scale.
The text stresses that screening for delirium using standardized daily cognitive instruments is critical, especially in intensive care units. You cannot rely on just looking at a patient from the doorway.
No, you have to actively test their complex attention, because the historical treatments for delirium have been deeply, deeply misguided.
The source goes incredibly hard on this. For decades, the knee-jerk reaction in medicine to a delirious, agitated patient was to heavily sedate them.
Just drug them.
Give them a shot of Haldol or another antipsychotic drug.
Yeah.
But the latest research shows that antipsychotics do absolutely nothing to cure the underlying delirium, except maybe temporarily masking severe, immediate physical aggression.
Think about the mechanism we just discussed. Delirium is an acute failure of brain networks due to inflammation and neurotransmitter chaos. You cannot drug an orchestra into playing better by throwing a heavy sedative at the conductor. It just doesn't work. The text reveals that the actual effective treatments are multi-component behavioral and supportive interventions.
Let's get specific on what that means. If drugs don't fix the house fire, how does a behavioral intervention put it out?
It means removing the physiological stress on the brain.
Okay.
It means making sure the patient has their glasses and hearing aids on, because sensory deprivation fuels hallucinations.
Because if you can't see or hear clearly, your brain just invents terrifying things to fill the void.
Exactly. It means strictly regulating their sleep-wake cycles by throwing open the blinds during the day and keeping the room completely dark and quiet at night, which helps reset their natural melatonin and acetylcholine rhythms.
Which hospitals are notoriously bad at doing.
Awful at it. It also means having family members consistently present to orient them, keeping them aggressively hydrated, and physically getting them out of bed to walk.
The text literally states this provides a model for the re-engineering of acute hospital care.
It's a massive paradigm shift.
It's suggesting that we have to pivot away from a purely pharmacological approach, just handing out chemical restraints, to a deeply environmental and behavioral approach. We literally have to redesign the physical hospital experience to protect the brain.
It's a necessary revolution, frankly. The standard acute care environment today is often actively toxic to the vulnerable brain.
So if a hospital UTI is a temporary storm that passes when the infection clears and the environment is managed, what happens when the weather never clears?
That's the transition to dementia.
Because the text notes that certain late-stage dementias have chronic presentations that are virtually indistinguishable from delirium. How does an A&E doctor look at a confused 80-year-old and know if it's an overnight storm or a 10-year fade?
The key discriminator is temporal onset. A doctor has to act like a forensic investigator.
Right.
They have to interrogate the family timeline. Did this profound confusion start 48 hours ago when the patient developed a cough and a fever? That acute timeline points straight to delirium. Or has this been a slow, agonizing progression over the last 4 years, with the patient gradually losing the ability to balance their checkbook, followed by getting lost driving, followed by today's confusion? That points to a progressive neurodegenerative disease.
Which brings us to those chronic progressive fades. And the absolute giant in the room is Alzheimer's disease.
Yes. The source text highlights some incredible, though complex, advances in our understanding of Alzheimer's, specifically zeroing in on the amyloid hypothesis.
The amyloid hypothesis.
Historically, we knew Alzheimer's was associated with two physical hallmarks found in the brain after death: amyloid plaques and tau tangles. But for a long time, we didn't know which one was the match that started the fire and which one was just the ashes.
But now science is identifying mechanisms showing that the accumulation of a specific protein amyloid beta interferes with cognitive function long before those classic hard plaques even form.
Let's break down the cellular mechanics of that, because it's vital. Every brain produces a larger protein called the amyloid precursor protein, or APP. It sits in the membrane of your neurons. Normally, enzymes act like little molecular scissors and snip this protein in a specific way so the waste can be easily washed away.
Routine maintenance.
Exactly. But in Alzheimer's, a different set of scissors, called beta secretase, snips the protein in the wrong spot. This creates amyloid beta, which is a sticky, misfolded fragment.
And because it's sticky, it doesn't just float away, does it? These fragments start clumping together.
Precisely. Before they even harden into giant plaques, these small clumps, which we call oligomers, float into the synaptic cleft.
That's the microscopic gap between two neurons where chemical messages are sent.
Yes. The sticky oligomers physically block the receptors. It is literal cellular garbage obstructing the communication lines.
So the musicians in the string section are trying to play, but there is physical trash wedged between their instruments.
That's exactly it.
But the brain has a waste management system, right? Why doesn't it just sweep this garbage out?
It does, through something called the lymphatic system. You can think of it as the brain's night shift janitorial crew.
I love that.
When you enter deep, slow-wave sleep, the glial cells in your brain actually shrink in size.
Oh, wow.
This shrinkage allows cerebrospinal fluid to rush in and literally wash the metabolic trash, including that sticky amyloid beta, out of the brain tissue and into the liver for disposal.
That happens every night.
Every night. But as we age, or if our sleep is chronically disrupted, that janitorial system becomes incredibly inefficient. The trash piles up faster than it can be cleared.
And that buildup of trash kicks off the secondary disaster, doesn't it? The tau tangles.
Yes.
So the amyloid is building up outside the cells, but that external stress causes a completely different protein tau collapse inside the cell.
Tau normally acts like railroad tracks, transporting nutrients down the long arms of the neuron.
Right.
When tau collapses into tangles, the railroad tracks fall apart, and the neuron literally starves to death from the inside out.
That dual mechanism amyloid blocking the outside, tau starving the inside, is the core pathology of Alzheimer's. And understanding that amyloid initiates the whole cascade is what led the FDA to controversially expedite approval for two anti-amyloid therapies, aducanumab and lecanemab.
Yes, the monoclonal antibodies.
The text explicitly notes that clinical trials treating patients with these agents showed limited efficacy. They are lab-made immune proteins designed to seek out and destroy that sticky amyloid trash. But if they clear the trash, why is the efficacy limited?
Because by the time a patient is showing clinical symptoms of memory loss, the amyloid fire has already triggered the tau tangles and widespread neuronal death.
The damage is done.
Exactly. Clearing the amyloid at that late stage is like finally putting out a fire after the house is already burned down. It might slow further damage, but it doesn't magically rebuild the dead neurons.
So why did the FDA expedite them?
The FDA's expedited approval, despite this limited efficacy, reflects the sheer clinical desperation. The burden of this disease is so catastrophic that there is an overwhelming imperative to give doctors a tool that modifies the underlying disease process rather than just treating the symptoms.
It's better than nothing, essentially.
Basically, yes.
Well, while the pharmacology is fighting an uphill battle, the text pivots to something vastly more empowering: early identification and risk factors.
Correct.
This is where you, the listener, actually have immense control.
Yes.
The text points to vascular risk factors, diabetes, hypertension, inflammation.
The connection between heart health and brain health simply cannot be overstated. Your brain represents about 2% of your body weight, but it consumes 20% of your oxygen and blood supply.
It's greedy.
It is incredibly metabolically demanding. If you have chronic hypertension, high blood pressure, every heartbeat is hammering blood too forcefully into the delicate microscopic vessels that feed the brain.
You are literally battering the tiny pipes that deliver oxygen to your memory centers.
And when those microscopic pipes become damaged or stiffen, they can't deliver enough oxygen. The neurons become stressed. And what happens when a neuron is stressed?
It produces more amyloid.
Exactly. It produces more of that sticky amyloid beta, and its internal tau proteins are more likely to collapse. A vascular problem directly accelerates the neurodegenerative Alzheimer's pathology.
That exact mechanism explains the protective measures the text highlights. These aren't just fluffy wellness tips. This is hardcore epidemiological defense.
Absolutely.
The frontline defenses against structural brain decay are physical exercise and specific diets, namely the Mediterranean-diet or the MIND diet.
The MIND diet, which stands for Mediterranean-Intervention for Neurodegenerative Delay, is incredibly specific. It focuses heavily on leafy greens, berries, nuts, and healthy fats like olive oil.
And look at the cellular impact of those foods.
Yeah.
Berries, for example, are packed with anthocyanins, which cross the blood-brain barrier and act as powerful antioxidants. They neutralize the free radicals that cause oxidative stress, which is one of the triggers that causes the APP protein to be snipped incorrectly into amyloid beta.
So physical exercise keeps the blood vessels flexible to prevent microscopic brain damage. The MIND diet provides the chemical shields against cellular stress, and good sleep opens the floodgates for the lymphatic janitors to wash away the daily trash.
It's a complete defense system.
It is. Add in the final protective factor the text mentions: social engagement.
Oh, this is fascinating.
Interacting with other humans is the most complex cognitive task we perform. It requires rapid-fire use of language, memory, complex attention, and emotional regulation.
You're using all the instruments at once.
Exactly. Socializing forces the brain to constantly forge new neural connections. It builds a thicker, more robust network that can withstand more damage before showing symptoms.
But even with the best defenses, things go wrong. And the brain doesn't neatly separate its disasters into perfect categories. The text points out that pure dementia syndromes are relatively uncommon.
Very uncommon.
When pathologists look at brains after death, they rarely find just Alzheimer's, do they?
No, they find mixed pathologies. A chaotic combination of Alzheimer's plaques, vascular damage from hundreds of silent mini-strokes, and sometimes Lewy bodies, which are clumps of a totally different protein called alpha-synuclein.
The boundaries between these diseases are incredibly diffuse in a living patient.
But technology is finally giving us a window into that chaos. The text mentions the approval of agents for in vivo imaging of amyloid and tau proteins.
Meaning we don't have to wait for an autopsy anymore.
Exactly. Doctors can use specialized PE scans, injecting a radioactive tracer that binds specifically to amyloid or tau to literally watch the proteins depositing in a living brain in real time.
That imaging is critical because tau pathology isn't exclusive to Alzheimer's. It extends out to define a whole other set of devastating neurodegenerative dementias. And the most prominent among these is frontotemporal dementia, or FTD.
This is where the narrative of cognitive decline takes a very dark, very complex turn. Because, as we mentioned earlier, FTD attacks the frontal and temporal lobes. It attacks the conductor.
The text explains that FTD is driven by both tau pathology and non-tau, ubiquitin positive inclusions. Let's explain what ubiquitin actually is.
Please do.
Ubiquitin is a tiny protein that acts like a sticky note for the cell's garbage disposal system. When a protein inside the cell is old or misfolded, the cell attaches a ubiquitin tag to it, marking it for destruction by the proteasome. It's the cellular kiss of death.
But in FTD, that trash disposal system completely jams up.
Right.
The misfolded proteins gather so many ubiquitin tags, but they refuse to be destroyed. They clump together into massive toxic inclusions inside the frontal lobe neurons, eventually suffocating the cell.
And because this physical death happens in the frontal lobe, the seat of personality, empathy, and impulse control, the first symptoms are almost never memory loss.
No. The first symptoms are bizarre, sudden behavioral changes. A complete loss of social filter. Apathy, hypersexuality, compulsive eating.
And this leads to one of the most staggering statistics in the entire source text. Up to 50% of individuals with the behavioral variant of FTD are initially misdiagnosed with a primary psychiatric disorder.
Half of all patients. The tragedy of that misdiagnosis is immense.
Let's visualize that. You have a 55-year-old woman. She's a successful accountant, a loving mother, totally normal life. Suddenly, she starts making wildly inappropriate sexual comments to strangers at the supermarket.
Out of nowhere!
She stops caring about her children. She starts eating a jar of mayonnaise with a spoon. Her memory of her accounting spreadsheets is totally fine, so her family drags her to a psychiatrist.
Naturally.
And the psychiatrist diagnoses her with late-onset bipolar disorder or a severe personality disorder. But in reality, the neurons in her frontal lobe are physically suffocating from ubiquitin inclusions.
The family spends years angry at her for her behavior, trying to fix her with psychiatric medication and therapy, entirely unaware that she has a terminal neurodegenerative disease.
That is heartbreaking.
It is. The text highlights that the Neuropsychiatric International Consortium for Frontotemporal Dementia had to develop highly specific diagnostic guidelines just to help clinicians distinguish the physical decay of FTD from pure psychiatric disorders.
Because they look so similar on the surface.
Exactly. And FTD also carries a terrifying genetic component. The text notes that 20% of FTD cases are caused by a direct autosomal dominant genetic mutation, and 40% have a strong family history.
They list the specific genes, MEPT, GRN, and C9orf72. What are those genes actually doing?
Well, take the GRN gene, for example. It provides instructions for making a protein called progranulin.
Progranulin.
Progranulin is crucial for regulating inflammation in the brain and helping lysosomes, the cell's recycling centers, function properly. If you have a mutation in the GRN gene, your brain doesn't produce enough progranulin.
So what happens without it?
Without it, the brain's immune cells, called microglia, become hyperactive and start indiscriminately attacking healthy brain tissue in the frontal lobe. It is a hardwired genetic self-destruct sequence.
Just as science maps out the genetics of FTD, the text introduces us to a newly categorized entity that proves our map of dementia is still actively being drawn. LATE.
Ah, yes.
Which stands for limbic predominant age-related TDP-43 encephalopathy.
LATE is a really fascinating development. For decades, doctors looked at 85-year-old patients with severe memory loss and just blanketly assumed it was Alzheimer's.
Sure, memory loss equals Alzheimer's.
Right. But when pathologists examined these brains, they didn't find amyloid plaques or tau tangles. They found a completely different misfolded protein, TDP-43.
What does TDP-43 do in a normal brain?
In a healthy neuron, TDP-43 lives safely inside the nucleus, acting like a librarian. It reads the DNA and helps edit the messenger RNA so the cell can build necessary proteins.
Okay, so it manages the information.
Exactly. But in LATE, the librarian escapes the library. TDP-43 leaks out of the nucleus into the main body of the cell, the cytoplasm, where it forms toxic clumps.
Oh, wow.
Without its librarian, the nucleus can't read its DNA properly, and the cell dies.
The text describes LATE as occurring typically in the oldest old, patients over the age of 80. It presents as a progressive amnestic syndrome, severe memory loss, that mimics Alzheimer's perfectly, but the physical decline is generally more gradual.
It proves that the older the brain gets, the more vulnerable it is to a wide variety of different protein folding errors.
Regardless of whether the destruction is caused by amyloid, tau, ubiquitin, or TDP-43, the source text forces us to confront the universal and often most agonizing reality of all these dementias: the behavioral and psychological toll.
Yes, the behavior.
The text states that the course of nearly all subjects developing progressive dementia is complicated by behavioral syndromes: anxiety, deep depression, sleep-wake reversals, delusions, paranoia, and physical aggression.
This is the absolute crux of the issue for caregiving and healthcare infrastructure. A family can usually manage pure memory loss at home.
Yeah, you adapt.
You put sticky notes on the cabinets, you use pill organizers, you disable the cooker. Memory loss alone rarely puts someone in a nursing home.
Right.
But when a patient develops severe paranoia, when they are convinced their daughter is an imposter trying to poison them, when they start wandering into traffic at 3 in the morning, or when they become physically violent toward their spouse.
Those are the breaking points.
Those are the symptoms that completely break a family's physical and emotional ability to care for them.
The text notes these behavioral symptoms are a prominent reason for institutional care. But the bleakest part of the text is how we treat it.
It is bleak.
It states that pharmacologic interventions for these behavioral disruptions have limited effectiveness and carry significant risks of morbidity and mortality.
We have to look at the pharmacology of why that is. When a patient with dementia becomes aggressive, the historical medical reflex is to prescribe a heavy antipsychotic.
Just chemically restrain them.
But antipsychotics work by blocking dopamine receptors in the brain. If you block dopamine in an 85-year-old brain that is already degenerating, you induce Parkinsonism.
Meaning what exactly?
They become stiff, their balance fails, and they suffer catastrophic falls. Furthermore, these drugs alter the electrical rhythm of the heart, leading to fatal arrhythmias, and they significantly increase the risk of blood clots and massive strokes.
You're essentially using a chemical restraint that accelerates their death.
That is the grim reality of it, yes.
That is why the text emphasizes a massive ray of hope in non-pharmacological approaches. Specifically, behavioral treatments like the DICE method, which have shown incredible promise.
DICE is a structured framework that forces caregivers and clinicians to step back and act like detectives, rather than just reflexively pulling out a prescription pad.
I love this. DICE stands for Describe, Investigate, Create, and Evaluate. Let's role-play how that actually works in reality, because the concept sounds simple, but the execution requires a total shift in perspective.
Okay, let's do it.
Let's say I'm a caregiver, and my father, who has moderate Alzheimer's, starts throwing his dinner plates at the wall every single day at 4 p.m. My instinct is to call the doctor and ask for a pill to calm him down. How does DICE change that?
DICE forces you to recognize that all behavior is a form of communication, especially when the patient's language domain is physically failing. They can't tell you what's wrong, so they show you.
Right.
So step one is describe. You don't just say he's aggressive, you note the exact pattern. It only happens at 4 p.m. in the dining room when he's sitting by the window.
Very specific.
Step two is the most critical. Investigate. You look for the trigger. Is he in physical pain from an undiagnosed cavity or a UTI, or look at the environment? At 4 p.m. in the winter, the sun sets.
Okay, yes.
Are the shadows from the trees outside creating shapes on the wall that his damaged occipital lobe misinterprets as intruders? Is the glare from the window blinding him?
So it could be a visual processing error causing terror?
Exactly. Step three, create. You create a targeted intervention. You pull the curtain shut at 3:30, turn on bright overhead lights to eliminate shadows, and give him a warm cup of decaf tea before dinner.
Changing the environment.
And step four, evaluate. Did the plate throwing stop? If yes, you solved it without a single milligram of medication. If no, you go back to the investigation phase.
It is treating the patient as a deeply vulnerable human being reacting to an environment they no longer understand, rather than treating them as a broken machine with a behavioral glitch that needs to be chemically switched off.
Beautifully put.
It requires time, patience, and human capital, which the medical system frankly struggles to provide.
It does struggle, but incorporating these behavioral symptoms into a neurobiologic framework is the only humane way forward. We have to treat the environment because we cannot yet cure the brain.
But before the brain reaches that stage of irreversible decline, before the ubiquitin jams the system or the amyloid burns down the synapses, there is a massive window of time.
A crucial window.
The text shifts focus to early warnings and incredibly reversible realities. Let's look at mild cognitive impairment, or MCI.
Mild cognitive impairment is exactly what it sounds like. It's a measurable decline in cognitive abilities that goes beyond normal aging. But the text gives us the key differentiator between MCI and full-blown dementia, the lack of functional impairment.
So a person with MCI might struggle to recall a word, or they might need to write down their appointments more frequently, but their executive function is still intact enough that they can drive a car safely, pay their own bills, and live independently.
Precisely. However, the text issues a stark clinical warning. When MCI presents as an isolated amnestic symptom in late life, meaning the only deficit is short-term memory loss, it heavily predicts the subsequent onset of Alzheimer's disease.
It is the canary in the coal mine.
It really is.
And this leads to perhaps the most mind-blowing and crucial concept in the entire source text, preclinical Alzheimer's. The text states that neurodegeneration may precede clinical symptoms by 10 years or more, a full decade.
Let the biology of that sink in. The amyloid beta is being incorrectly snipped, the oligomers are piling up in the synapses, the tau proteins are slowly collapsing inside the neurons.
The brain is actively shrinking.
Yes. This physical destruction is quietly raging in the brain for a decade before the patient ever forgets where they put their keys. The biological markers of the disease are there, but the outward behavior is completely normal.
This is such an empowering takeaway for you listening. If you are 65 and starting to show the first signs of memory loss, the disease actually started eating your brain when you were 55.
10 years earlier.
Your brain's health in your 70s is being determined by your physical habits in your 50s. That 10-year window is the battlefield.
It is the time to act.
That is when you need to be doing the rigorous physical exercise to protect your blood vessels, eating the anthocyanin-rich berries, managing your blood pressure, and getting deep sleep to activate your glymphatic janitors. You are fighting a silent war years before you know you're under attack.
It demands profound, proactive health measures. But the text also brings up a critical point about cognitive decline in older adults.
Right.
Sometimes an older patient suddenly develops severe cognitive symptoms, not because the underlying Alzheimer's suddenly accelerated, but because of a completely independent, reversible cause.
This is where we talk about the fact that not all dementia is a death sentence. Some of it is entirely preventable or even curable. The text spends time detailing a devastating yet highly treatable condition, Wernicke syndrome.
Wernicke syndrome is the ultimate tragic example of a preventable metabolic brain disaster. It is caused by a severe deficiency in thiamine, which is vitamin B1.
How does thiamine deficiency actually destroy the brain?
Thiamine is a mandatory coenzyme in the Krebs cycle. It is the molecular key that allows brain cells to metabolize glucose.
Oh, I see.
Without thiamine, a neuron literally cannot convert sugar into energy. The cells rapidly suffocate. The mammillary bodies, which are tiny structures deep in the brain that are central for memory formation, are incredibly sensitive to thiamine depletion.
And when they suffocate,
They undergo necrosis. The tissue physically dies.
the text lists the primary culprits for this deficiency: malnutrition, severe vomiting, but predominantly severe alcohol use disorders.
Yes.
Alcohol essentially poisons the gastrointestinal tract's ability to absorb thiamine, while simultaneously increasing the body's demand for it.
And the clinical presentation is dramatic. It presents as acute delirium, severe amnestic symptoms, and physical unsteadiness. The orchestra is completely falling apart because the musicians are literally starving to death.
But the crucial difference here is the speed and nature of the treatment. The text states that treatment with high-dose intravenous thiamine can stop this process in its tracks.
If caught early.
Right. If caught early in the Wernicke stage, you restart the metabolic engine and reverse the delirium.
But if you miss it, or if the doctor assumes the patient is just intoxicated and lets them sleep it off without thiamine, the necrosis becomes permanent.
It progresses to Korsakoff syndrome.
Yes. The text uses a terrifying word here: irreversible. The memory centers are dead. The patient permanently loses the ability to form new memories, a condition known as anterograde amnesia.
A simple, cheap vitamin deficiency, if ignored for just a few days, can permanently destroy a human being's timeline.
It's tragic.
And thiamine isn't the only mimic. The text has a whole section dedicated to cognitive disorders due to other medical conditions or substances. It's a massive checklist of things that look exactly like dementia, but aren't.
It is the mandatory checklist for any clinician doing a differential diagnosis. The text mentions neurologic issues like silent strokes or tumors.
Right.
It mentions infectious disorders like HIV and advanced syphilis, which literally eat the brain tissue. It mentions endocrine disorders like severe hypothyroidism, where a lack of thyroid hormone slows the brain's metabolism to a crawl, mimicking a neurodegenerative fade.
And then there are the everyday substances. The text specifically implicates prescribed and over-the-counter drugs, things with anticholinergic properties, anxiolytics, and sedative hypnotics. Let's look at the anticholinergics because this affects millions of people.
Anticholinergic drugs block the action of acetylcholine. We mentioned earlier that acetylcholine is the primary chemical messenger the brain uses for learning, memory, and complex attention.
Yes, the crucial neurotransmitter.
When you take a drug that blocks those receptors, you are artificially inducing a state of memory loss and confusion.
And what kinds of drugs do this? Common over-the-counter allergy medications like diphenhydramine Benadryl, many over-the-counter sleep aids, medications for overactive bladders.
Take an 80-year-old brain that already has a slightly lower baseline of acetylcholine. Give them a strong over-the-counter sleep aid with anticholinergic properties every single night. Add in an anxiolytic and anti-anxiety medication like a benzodiazepine prescribed by their doctor for mild anxiety. You will induce a state of profound cognitive impairment, confusion, and memory loss that looks exactly symptom for symptom, like moderate Alzheimer's disease.
So if a listener has an aging parent who suddenly seems confused, forgetful, or a little paranoid, before anyone panics and assumes they need to start looking at memory care facilities, they need to empty out the medicine cabinet.
Absolutely. Review everything.
They need to look at the interactions. Because if you stop the sleep aid and taper off the anti-anxiety medication, the dementia magically vanishes.
This disappears.
The text concludes that optimum care requires immense detective work. You cannot slap a dementia label on a patient without exhaustively ruling out the reversible mimics first.
The human brain is far too complex to assume that every behavioral failure or memory lapse is a permanent structural collapse. Sometimes the orchestra is just playing in the dark because a medication turned off the lights or a vitamin deficiency took away their sheet music.
You have to find the switch.
You really do.
Let's synthesize everything we've uncovered today. We've journeyed through an incredibly dense, profound landscape of human biology. We started with the beautifully interdependent orchestra of cognition, memory, executive function, complex attention-all firing, and perfect harmony.
We covered a lot of ground.
We navigated the sudden neuroinflammatory storms of delirium in the hospital ward. We zoomed in on the microscopic slow-motion disaster of amyloid beta, blocking the synapses and tau tangles starving the cells in Alzheimer's.
Right.
We confronted the heartbreak of misdiagnosis and FTD when ubiquitin inclusions destroy the frontal lobe and the behavioral conductor goes rogue. We found actionable hope in the rigorous detective work of the Dicey method and the vascular defense of the MINE diet.
And the mimics.
Yes. And we ended on the vital imperative of checking for reversible mimics, so we never condemn a brain that simply needs a vitamin or a medication adjustment.
It is a remarkable synthesis of exactly where modern medical science stands on the front line of cognitive care. But I want to leave the listener with a final lingering thought based on the biology we've discussed today. Please do.
We talked extensively about that 10-year preclinical window in Alzheimer's. The silent period where the physical neurodegeneration is happening quietly long before the first symptom appears.
A battlefield.
If the physical pathology of dementia begins a decade before the memory actually fails, it means that right now, at this very exact moment, your brain is actively building the scaffolding it will use to defend itself in the future.
Wow.
Neurologists call this cognitive reserve. Every single new language you try to learn, every brisk walk you take that pumps fresh, oxygenated blood to your prefrontal cortex, every dense social connection you nurture, is literally changing the physical architecture of your mind.
You're physically altering it.
You are laying down extra neural tracks, building redundant communication systems, so that if the amyloid oligomers do start to accumulate and block a pathway, your orchestra has backup pathways to keep the music playing smoothly.
That's incredible.
The biology dictates that you are not powerless. The question I want you to mull over is simply this: what neural architecture are you building today to protect your mind tomorrow?
That is the perfect, empowering note to end on. Thank you for joining us on this intense, illuminating deep dive into the human mind. The brain is incredibly fragile, yes, but as we've seen today, it is also remarkably, beautifully resilient when we actually understand the mechanisms of how to care for it. Keep building that scaffolding, keep playing the music, and we will see you next time.